Hello and welcome to the Spine and Nerve Podcast. My name is Dr. Brian Joves.
And my name is Dr. Nicolas Karvelas.
And we're going to continue on our journey back into the early steps and stages of pain medicine. And we're going to talk about one of the most common things that people present with to our practice and probably to a lot of practices that do spine medicine. We're going to go and talk about radiculopathy, particularly with a tilt on acute radiculopathy today, which is a little bit different than many of the things that we talk about, because most of the things that we discuss are chronic conditions that are presenting after months to years of a patient dealing with symptoms. We're going to kind of talk about this a little bit more from the acute side so that we can kind of differentiate where this pathology stands as opposed to how many of our patients present to us. So Dr. K, give us a little intro.
Yeah, and so in the context of speaking about acute lumbar radiculopathy today, we will talk about, just as a brief overview, we'll talk about the definition as well as the cause of acute lumbar radiculopathy, some risk factors, then importantly, the natural history. I think we'll spend a good amount of time emphasizing that. And then lastly, pathophysiology. We'll probably save discussions regarding management, the complete workup and management of radiculopathy until later when we're discussing a patient case presentation. We'll probably go a little bit more into treatment, and then potentially, obviously, with the journal article, we may talk a little bit more about treatment as well. But like I said, today we predominantly want to cover the definition, causes, risk factors, natural history, and pathophysiology.
Yeah, no, I think that's good. And I think anytime that we start with these discussions, my favorite thing, especially when talking to patients or medical students who are early on, is kind of first starting about the disc, right? Because obviously the disc is the center point, generally speaking, of an acute lumbar radiculopathy. And so my favorite way of thinking about the disc is jelly donuts, because I love jelly donuts. You got the tough outer portion, the squishy inner portion. And obviously, if you put pressure in different directions, you can make some of the jelly squeeze out of the donut. And I think it makes for a nice analogy to the disc, with having the annulus fibrosus and the nucleus pulposus, and then kind of gives a nice segue into kind of understanding how that disc is going to start interacting with the nerve.
Yeah, definitely. And when we talk about the causes of acute lumbar radiculopathy, that'll come into play, where the majority of the causes of acute lumbar radiculopathy are going to be structural due to disc and or bony pathology. But we'll talk about the fact that the differential diagnosis is very broad for radiculopathy. So starting with definition. So definition of acute lumbar radiculopathy. So this is a new onset, duration less than 6 to 12 weeks. And the reason I bring up that 6 to 12 weeks is because looking at the majority of literature that's studied the natural history of these, the majority of cases of acute lumbar radiculopathy are actually going to resolve by this time. So once you start to get past those time points, you would start to be considered more of a subacute to chronic disease process at that point. So as I said, new onset, duration less than 6 to 12 weeks, disease process defined by injury of the nerve root in the lumbar spine, typically presenting as pain and paresthesias in the distribution of the nerve root, accompanied by sensory and or motor abnormalities. And just as a quick reminder, when we say radiculitis versus radiculopathy, so radiculitis essentially meaning that on exam, there's no objective findings of neurologic deficits. However, the patient's history and overall clinical presentation is still very consistent with a radicular pain process, in contrast to radiculopathy, where you will find either sensory or motor deficits or reflex changes on exam. So you have some objective evidence.
Yeah, and for reference sake, we will attach a dermatome chart to the show notes. Hopefully most people who are listening to this have seen the dermatome chart, but it does, when Dr. Karvelas is talking about in a specific nerve root pattern, those are the patterns that we are talking about.
Yeah, and so now moving on to the causes of radiculopathy. So as Dr. Joves brought up in the beginning, definitely in terms of the most common causes, we're thinking about disc herniation. However, like I said, the differential diagnosis does end up being very broad, and it's important to keep your mind open to these different possibilities, especially, which we'll bring up towards the end, when you are fairly convinced that there's something going on in terms of radiculopathy, but maybe the imaging is not necessarily concordant with that, and you start to think about these more rare cases of radiculopathy. So bottom line is there are a vast number of causes of radiculopathy, so keep that differential diagnosis broad. The most common cause is structural, so specifically disc herniations, as we brought up, or impingement due to spondylosis. That being said, as we said, it's important to keep our mind open to these other potential causes. And we're not going to go over every single cause, obviously, today, but some important general categories to keep in mind would be degenerative conditions of the spine. So this would include acquired pars defects and listhesis, trauma. So especially in the elderly, because obviously in a young person, you can have a high energy, high impact trauma that can lead to a burst fracture and radiculopathy. But in an elderly patient, it may be a more subtle course in terms of developing this, because even low energy injuries or even spontaneous burst fractures can occur in an elderly osteoporotic patient, leading to a radiculopathy. Tumors, so obviously benign or malignant tumors, and keeping in mind that typically in the spine, metastatic tumors are going to be the most common tumor, ultimately causing the radiculopathy. Infection, so keeping in mind osteomyelitis, epidural abscess, different infectious process can cause radiculopathy. Vascular conditions, including AVMs. And then it's also important to keep in mind that radiculopathy may also be due to microscopic causes, and it can occur on that microscopic level. So, and ultimately without evidence of a mass lesion on imaging. So these can be due to things such as infiltration by tumor, infiltration by granulomatous tissue, infections such as Lyme disease, or even infarction in the setting of vasculitic neuropathy. In these scenarios, the imaging may look normal potentially, and that's where the EMG nerve conduction study has even more value in those scenarios, especially if your clinical suspicion is high.
Yeah, and just because I know that we have medical students listening to us, Dr. Karvelas brings up those as a vast differential, but generally speaking, especially when we're talking about the acute processes, we're talking about some type of force or change in the anatomic structure that's going to be presenting pressure to the nerve root as the vast majority of these cases.
Yep. Now, in terms of risk factors for development of radiculopathy, and as we've brought up multiple times here, and Dr. Joves just emphasized again, when we're talking about risk factors here, we're going to focus on radiculopathy due to disc herniation, especially since that's one of the prominent causes. So there was a trial called the SPORT trial, Spine Patient Outcome research trial, that looked at risk factors for radiculopathy due to disc herniation. And essentially the risk factors they found were smoking tobacco, obesity, diabetes, hyperlipidemia, and then genetic as well. And then, so I just want to emphasize a couple of these things. So smoking tobacco, I know we've talked about this in the past, but I do think that's critical to emphasize to patients, because usually the way I present it is letting them know that, hey, knowledge is power, and we want you to have as much information as possible. We know that you've heard over and over again the increased risk of cardiovascular disease and cancer and other general health issues with smoking. But you're in here maybe on a monthly basis and potentially taking medications, getting injections for your back pain. And look, we know that smoking is a risk factor for not only the development, but the persistence of back pain. Just like we have small blood vessels going to our heart and lungs, and smoking can contribute to heart disease and lung disease, we have small blood vessels going to our disc and to our joints and our spine as well. And so smoking compromising the optimal blood flow to those structures especially the disc, which is already a very tenuous situation in terms of blood supply to begin with. If you can achieve smoking cessation, you can have a significant impact not only in your current symptoms, but the development of symptoms moving forward, or worsening of symptoms moving forward. So I think that's always an important thing to emphasize to patients.
Yeah, and obviously today we're kind of trying to err a little bit more towards the acute radiculopathies, which obviously smoking is a significant risk factor, but we have covered smoking in depth previously, talking about how it is correlated and linked to chronic back pain. So we'll also reference that in the show notes if anybody wants to go back and hear us give a nice 15 to 20 minutes of deep dive into smoking. But it is not only chronic conditions that smoking leads to, it also does have some effect and is a significant risk factor for acute herniations as well.
Yep, and genetic as well. I know that that's not, I don't think quite as discussed in terms of risk factors for disc herniation, but it's interesting. The odds ratio is not a small odds ratio. The studies that have looked at this have an odds ratio of 3.5, and the thought process being that the genetic change is in a gene coding for collagen, and as Dr. Joves brought up, that disc is so critical and its different components. Typically, the annulus is going to be composed predominantly of type 1 collagen and fibroblast type of cells versus the nucleus pulposus being more type 2 collagen, and the having a compromise in the integrity due to a certain genetic predisposition to the strength of that annulus fibrosis obviously leads to quite a bit of an increased risk of disc herniation ultimately.
Yeah, one of the other things that does play in also when we're thinking of genetic predisposition, there are different size canals for different people. I personally tend not to hark on this a lot. I know patients really gravitate to this concept. They read on their MRI or somebody mentions to them that they have a congenitally small canal, which is true, right? There are canals that are different sizes, and obviously a smaller canal gives less room for herniations to be asymptomatic. But patients really kind of feed off of those type of things also, and so I think I'm always personally cautious about it, but that does play in as well.
Yeah, definitely. All right. So now in terms of the natural history, so it's very important ultimately for clinicians to educate patients that the vast majority of cases of acute lumbar radiculopathy are going to heal and improve on their own over time. So research such as a well-known study by Dr. Gugliotta and his colleagues published in the British Medical Journal in 2016 essentially found that over 90% of cases of radiculopathy due to disc herniation resolve on their own. If most literature, and obviously that's not the only article that has published similar results to that, but most literature will state that about 50% of cases resolve within 1 to 2 weeks, and about 90% of cases resolve in 6 to 12 weeks. And some theories in regards to how radiculopathy due to disc herniation resolves include a few different things, because I think that's always interesting to think about. You get this disc herniation and then there's some improvement, and the question being, well, interesting, how did that radiculopathy and even the disc herniation, the size of the disc herniation itself, improve? And so some theories in regards to that include retraction forces from the posterior longitudinal ligaments and the tension of that ligament, resorption by macrophage phagocytosis, as well as some level of immunologic reaction and dehydration of the herniated disc. So ultimately, as a consequence, it's clearly recommended to trial conservative management, taking all these things into consideration. So obviously, like we talked about, the education of the patient is critical, letting them know the natural course of this disease process, and then a trial of conservative management prior to moving to any more aggressive therapy. And obviously, that completely changes if we have situations like Cobb-Aquinas syndrome, which we won't go into too much depth today. But if you have rapidly progressive neurologic deficits, loss of bladder bowel function, that changes the game. And we're obviously no longer considering conservative management at that point. But in the setting of your typical acute lumbar radiculopathy, given this information that we know, it is appropriate to initially approach with conservative management.
Yeah, and and just in case anybody is thinking that Dr. Karvelas is quoting a study that was just recently done, and we may not have known this about natural history for discs for a long time. That was just the most recent evidence that has been shown showing the natural history. And Dr. Karvelas always likes to quote something that's very recent, but just so everybody is aware, the one that I learned was Webb first publishing it, and I believe it was in 1983, which means that study is older than Dr. Karvelas. So we have known about the natural history, and like you said, it's been repeated multiple times over history just to show that yes, that is true. We continue to find that the vast majority of patients, like Dr. K said, 85 to 90% of patients will resolve their symptomatology within that 6 to 12 month ratio. I usually average it out to about 9 when talking to patients about it.
Yeah, and along those lines, one more article, because I thought this one was pretty interesting, because it actually looked at the size of the disc herniation and whether or not the size of the disc herniation ultimately significantly impacted outcomes. So this was a study by Dr. Gupta and colleagues that was published in the Global Spine Journal in October of 2020. And it not only added to the literature demonstrating that most patients with acute radiculopathy can be managed conservatively, but it also investigated whether the size of the disc herniation and the percentage of the canal that was occupied by that disc herniation had any predictive value regarding patients that would fail conservative management and ultimately require surgery. And essentially what they found was that there was no predictive value of that, the size of the disc herniation and or percent occupation of the canal. So just some additional thoughts to keep in our mind when we're looking at that initial presentation of the patient, including the imaging.
Yeah, so now we kind of went through some of the natural history. We talked about that initial pathology. What's next?
So just as we wrap up here and get ready to move to the journal article next week, as well as the case presentation following, I just wanted to briefly bring up some pathophysiology. And the main thing that I wanted to emphasize here was that a lumbar radiculopathy really is a multifactorial disease process, and there's growing evidence in regards to that. So at this point, we know that there clearly is a mechanical component to it. We've brought that up, especially with the most common causes. There's clearly a mechanical component to it, but there's also an ischemic, an inflammatory, as well as neuropathic pain mechanisms as well. And so one way that I thought was interesting to think about this is the symptoms that the patient's presenting with and what type of pain that is, and the theoretical mechanism behind that, and then the molecules involved in it. So and obviously you can go through this kind of quite extensively, but I just wanted to bring up a few common present symptoms that patients will report when they present. So the first one was spontaneous intermittent shooting pain. So that type of pain, when we talked about the different types of being ischemic, inflammatory, mechanical, neuropathic. So that type of pain considered to be more neuropathic pain due to spontaneous ectopic discharge of the neuron and or DRG, dorsal ganglion, and abnormal activity of the sodium channels thought to be playing a major role there. When patients also report not just that spontaneous intermittent shooting pain, but when they're reporting more spontaneous ongoing relentless pain, that's thought to be due more to inflammatory pain, and the mechanism there being inflammation surrounding or within the dorsal ganglion, and molecules playing a role there, including TNF alpha, interleukin 1 and 6. And then the last symptom I wanted to bring up, because I hear this quite commonly from our patients as well, is just kind of this deep, relentless soreness. And that type of pain thought to be not only inflammatory, but also an ischemic component to it. And a part of the mechanism of that is a more acidic environment and a release of increased protons. So obviously, different things playing a role there, not only the TNF alpha, interleukin 1 and 6 from an inflammatory component, but the acid sensing ion channel also playing a role there in the setting of the increased protons.
That was one of the most detailed explanations of the various pain patterns for radiculopathy I've heard.
Well, yeah, and I think, like I said, the take-home message there is just that we're continuing, because, you know, what's the rationale behind doing these type of research studies, looking at, okay, what's the underlying mechanisms in radiculopathy? The thought process, like many disease processes in medicine, is the better we understand exactly what's going on, especially at a basic science level, then the better we can optimize our treatment options and exactly what medications and what injections and what injectate we're utilizing to treat the pathology.
Yeah, well, I think one of the more interesting things about that is, we're presenting acute lumbar radiculopathy, which I think for most people who do pain medicine, who do spine medicine, who care for any patients that have pain, would think of that as a fairly straightforward presentation. Especially within our world of chronic pain medicine, it's definitely one of the most straightforward presentations that we get. But then you present this, all of the different factors that are involved. And so even something that seems like it's relatively straightforward in terms of its case presentation has all of these multiple factors that are involved, all of the different inflammatory markers and different pathways. And so I think, it just shows that even though it's on the surface appears to be relatively straightforward, nothing involving pain is straightforward.
Yeah, I think part of that is because there's and the reason I think that this research is being done is because we see the cases where they don't resolve in that 6 to 12 week time period, and it becomes a huge major issue, obviously, with a lot of disability and major impacts both on an individual and societal level, and obviously low back pain and radiculopathy being a huge contributor to the overall chronic pain landscape. And so yes, it's important to know these things in an acute setting, but I think part of the reason and the drive behind the research is to better understand it so that we can help prevent those chronic cases, which end up being such a major impact, like I said, on the individual and societal level.
Yeah, absolutely. All right, guys. I think that kind of covers the verbal parts of the introductory lesson to lumbar radiculopathy. Please reference our YouTube channel. We have done, or Dr. Karvelas has walked us through the physical examination components for evaluating the lumbar spine, particularly when evaluating lumbar radiculopathy. I think that would be very helpful to kind of go from what we just talked about with the natural history, the pathophysiology, and that presentation that patients have. And then that'll walk you into the physical examination. And then we will come back next week with some more recent literature talking about lumbar radiculopathy, probably erring a little bit more towards the side of some of the treatment options that we have available. Dr. K, closing thoughts?
No, that's it. Have a good week.
All right, everybody, stay tuned for those legal disclaimers. And please, if you made it this far, drop us a message. Dr. Karvelas isn't really on social media anywhere, but if you message him enough on LinkedIn, possibly he'll get on. Let us know how we can be more engaging, provide better education for everybody, and the types of things that you would enjoy hearing so that we can continue to provide value for everybody out there. And yeah, once again, leave us a review. Stay tuned for those legal disclaimers.